Right, folks, I'd like to get started if I may. I'm not going to actually do very much talking today. You may or may not be glad to hear that. What we are going to have is a demonstration. Now, I've never done this before, so you'll have to bear with me as I think on my feet. And the idea is that we're going to look at falls as a common presenting sign, or symptom rather, for elderly people. Now, I'll get the boring stuff out of the way first, and that's to do with the epidemiology, all the stuff that you'll forget as soon as you walk out of the room, but I've got to say it anyway. Now, it's a very common condition, falling. It depends on the community that you survey, and that's why there are different percentages. Depends whether it's a long stay community, whether they are living out in the normal community, but the percentages vary. But one thing to say is that most of the falls that happen to elderly people are not serious. But if they are, if they result in a fracture, then that is a good predictor of mortality. Now, you might think that the incidence of falls would keep on rising as people get older. And it does to a certain extent, but it tends to drop off after the age of 85. And the reason for that is fairly obvious, hopefully. Anybody got a... This chat requires audience participation. So if you don't volunteer, I'm going to ask. What was that?
Impaired mobility.
Yeah, basically they're not walking about, so they can't fall over. It's suggested that there might be a female preponderance. This is perhaps not surprising, as the woman always sprains her ankle at the opportune moment in the movies. And there is a higher incidence of falls of people who are in institutions. So if families think that putting granny into a nursing home is a good idea to prevent them from falling, wrong. Much more likely to fall there if they are of the debility that requires nursing home care. Okay? Bear with me a minute. What about the causes of falls? I like to think of things very simplistically because I'm a very simplistic person. Instead of thinking about the causes of falls, let's think about the requirements for standing upright. Anybody like to volunteer for what the causes or what are the, why have I put the arrows where I put them?
Prevent yourself from falling.
That isn't what one of them is looking at, but okay.
Center of balance.
Sorry?
Center of balance. The arrow that's pointing to the waist, is that pointing to the center of balance?
Let's move this over a wee bit. Let's take them in turn now. What about this? A stable base, yes. You've got to have a stable base to stand on, you know. All right. What would not give you a stable base? Are your legs the same length as each other? Can you prove it? Why might your legs not be the same length as each other? Yep. Shortening. Anything else? No, tend to be both still the same length. A hip replacement, yeah, that's a possibility. Anything else? Why may one leg not be the same length as the other? Because you don't have a leg. It's not difficult. I mean, I'm not trying to catch you out. Okay? So you need two legs and they need to be the same length. Or at least you need a prosthesis that is the same length as the one you've still got. Other things that you might think about are contractures. If someone's contracted. People with Parkinson's disease tend to have flexure contractures and go up on their toes. And they also have postural instability. So they've got lots of reasons for falling over. Now, how about up here? What's that pointing to? Sorry? The heart, right. I even put it on the correct side, that's all right. What about the heart? Arrhythmias? Decreased cardiac output, yes. Somebody said something else at the back. Hypotension. What? From what cause? Shout. Dehydration, anemia. Drugs. What drugs? Diuretic. I can't hear you. I'm sure it's all very interesting, but I can't hear. Okay, alpha blockers, beta blockers, any antihypertensive that you can think of, anti-Parkinsonian medication. Lots of things can cause postural hypotension. Postural hypotension can occur on its own idiopathically in this age group. Okay? What about this? Eyesight. Why does that matter? Do blind people fall over? We're building up a picture. It's not necessarily one thing, it may be a combination. Yes, okay, poor eyesight. And what about this one? Ears? No, unless you don't hear the bus coming as it hits you as you walk across the street. Ears, a wee bit further in than that. Sorry? Yes, vestibular problems. Now, vestibular problems seem to be diagnosed an awful lot more often than they actually exist. Meniere's disease, for instance, isn't that common. The number of people that get put on prochlorperazine because they're dizzy is nobody's business. And it's not really the treatment of choice. But you certainly do get people who've got vestibular problems who maybe have a labyrinthitis. Now, how about this arrow here? Well, we've touched on that one, but let's take it a wee bit further on. Cerebellar problems, infarcts, space-occupying lesions. Anything else in that area? The bells, no. What? Stroke. Go on, go on, go on. Is there anybody out there? Dementia per se, no. People with dementia do not necessarily fall because of their dementia. They may have an increased risk of falling for one reason though. It's a kind of knock-on effect. You think of what it might be? Why did you say, now you've got your mouth full, why did you say dementia? He told you to, right? Okay. That seems as good a reason as any. They tend to lack safety awareness. They may be physically all right, but reach for things and they're not there, or they move, or whatever. Okay, so you need an intact base, you need good musculature, you need to be able to coordinate your balance, and anything that puts any of these off may give a propensity to falls. And then you can see I'm not an artist. What's the whole picture? Yes, that's quite reasonable. Environment was what I was thinking of. The environment in which the person lives may well give them a higher chance of falling. If they've got loose rugs on the floor, if they have to bend down to light a fire, pull out plugs, light sockets, all these sort of things, that's a distinct problem. Okay. Now, just bear with me a second, we'll just get all this stuff out of the way. And we require a couple of volunteers from the audience. So that'll be you and you.
First year we have too much.
I need a volunteer or two. Take all sharp implements out of your pocket.
Thanks a lot.
Right, I'd like you to stand just here, okay?
Here.
No, turn round. I want you to see where you're going. Now, you need to fall on this. There's no employer liability here, okay? You're doing your volunteering. Give me your beaker. Okay, if you just stand back a wee bit, okay? And turn round. Just face this way, okay? I want you to show me how a 60-year-old lady would fall.
You can do it.
No, wrong. She wouldn't do it like that. How do you think it would do it? Think about it again. Correct. Okay. What did you notice he did? Second time. Hands out. Okay. What would that result in? Colles fracture. Okay, I mean this all seems kind of daft. I'll have somebody else now. Somebody else. We'll have a lady this time.
Oh, sure.
Right.
My bones are old. They would break. Okay.
I need a lady.
She's older than I am.
How about Steve?
You need a young woman that still has a lot of estrogen. Yeah. That's right.
Okay. Now what I'd like you to do this time is to show us how an 85-year-old lady would fall.
I don't even know how I would fall.
Well, how would you fall then? You show me how you would fall. Go on you go. What would you do? You're fit and young. Nah. What a win. What a win.
I don't usually plan falls.
No, well, turn around again. Put your hands in your pockets, okay? Turn around that way. No, that's not it. That's not it.
What are you doing this time?
Until we get the desired effect. Right? Close your eyes. Just turn around a wee bit. No, we're still not doing it.
Hit my hip.
Just fall over gently. Go on. That way. Just fall. It's very difficult to fall, actually. Have you ever tried it?
I can't do it without bringing my hands out.
Well, that's your righting mechanism. Fall backwards. You fall backwards. Close your eyes. Close your eyes. You okay? That's okay. Thanks very much. Thanks very much. It's actually very difficult to do that without some training. What I was trying to demonstrate there was that, you know, a young person will actually save themselves. They probably won't fall. They'll try and catch on to something. An older person, about 60, a little bit of osteoporosis, will put their hands out and they'll get a Colles fracture. The 80-year-old one will not have any righting mechanism, won't put out their hands, and will fracture their hip. That's the kind of 3 ages of falling, if you like, and why there is a propensity to fracture neck or femur the older you get. Now, there's one or two other things that I would like to do. Afraid I'm going to have to ask you to get off that chair in a second. I wouldn't do that. I wouldn't do that. Now, this doesn't require to be fallen over. What I need somebody else now. I need somebody else. I'm going to spin you around. Come on. I'm going to spin you around. You sit here. You're not going to fall. No. What I want to do is demonstrate the final straw syndrome. Okay? The final straw syndrome. Now you're at the first stage. And there are going to be 3 stages of the final straw syndrome, all right? So what we're going to do is, this is a basic physiological test. God, you're heavy. Get your feet up off the ground. I'm going to wrap myself around you.
Just say
Put your feet on that bit. That's it. Okay. No, don't slow it down. That's it.
I hope you have the pie. Okay, can you start over again? So.
Right, hold on. The chair's coming to bit here. I really need a 2-stone weakling for this.
Let me tell you, I'll do it fast.
Okay, off you go. Right, okay, stand up. Stand up. Wait. Okay, that's what one would expect. Okay?
That's it?
No.
Stage 1.
That's stage 1. Okay, where are we? Stage 2. Oh, have another seat. Can we just put it around your leg? Going round your arm. Same.
Would you bring the mattress back?
Okay. Okay, would you like to spin yourself round again now? I have a feeling that this is not going to work, is it? Okay, we'd like to try and stand up now. You're waiting too long.
Didn't hear you.
Ah! Try it again. Get your exercise for the day. Try it again. Go round again.
Spin the other side first.
Any direction you like.
Oh, that was light-headed.
Don't believe a word of it. Well, I haven't finished yet. You sit back down again.
You sure you're not done?
Yes.
Come on, what to be done now?
Can somebody switch the lights out for me? Yes, flip these switches here. Okay.
You're not sure you you don't want the mattress back?
No.
Hey, you all look much better.
Okay, let's spin the wheel. It's only your eyes we've covered.
Yeah, you.
When I tell you to stand up, do so straight away.
Are you kidding me?
Keep on going. Faster. Okay, stand up. Very good.
Keep going.
You're far too fit. Okay. Well done. Well done. Yes, please. Thanks. Well, that didn't work. I'm obviously better at pushing people around than spinning them.
The steps better. Just offer.
I'm getting too old for that. What I was trying to demonstrate there was the fact that it may not be one factor that precipitates a fall, but a multiplicity of factors. So if someone has got just a little bit of postural instability because they feel a bit dizzy when they stand up, and then they have a stroke, let's say, and weakness on that side, and then perhaps their sight isn't very good, and they get up in the middle of the night. All of these things adding together are the straw, the final straw that breaks the camel's back. Okay, so it may not be, you may not be looking for any one particular thing. You may be looking for a train of circumstances that produce it. Now the last thing I need two people. This isn't going to hurt. You're not going to spin round. What I want somebody to do, your colleagues away. I was going to give her a chair back. I need someone to show me how they're going to teach somebody who's falling to get up off the floor. Can I have that chair, sir? That's a hint. I need one faller and one teacher. This the faller?
Even good fathers.
A faller, right. We need a teacher. That just requires you to stand up and point. How about yourself? You teach him how to get up off the floor. Come on. Right, if you would just like to lie face down, but face down, but facing this way. Okay. What a shame. He's fallen on the floor.
He's supposed to follow me.
That's how it's
Teach him how to get up off the floor. you've done all your tests and you haven't found a remediable cause and they're going to fall, and you want to give them reassurance that when they're on the floor, they can get back up off the floor. How are you going to teach them how to do that? Tickling them isn't allowed. And you've got to follow her instructions, okay?
Okay.
Can you make your feet?
Yeah, I think so.
Okay, your hands back.
I'll get my hand right there.
Put it out.
I'm gonna do.
Can you push against the floor?
Geez, what an awkward customer, eh?
Can you roll on your side? Okay. Can you sit now or?
You want me to sit?
But he wouldn't be able to do that, because if he would be able to do that, then he wouldn't have landed on the floor. In actual fact, you'd probably be lying on your back. He'd probably be lying on his back to kick off with rather than on his front. So what are you trying to do? What do you want him to try and do? You want him to get to stand up. But the chances are that he won't be able to stand up on his own. So he needs something to give him, he needs something to climb up. Viz the chair. Okay? So what do you reckon he should do? What do you reckon he should do? How is he going to get from where he is to grasping the chair and then climbing up the chair? Roll onto your side. That's it. Bring this knee up. Roll onto that knee. Bring the other knee up. Push with your hand. Bring them up so you're on your hands and knees. Grab the chair and stand up. There you are.
How you break his hand now and
There's going to be a time that even if you've done all your tests and you've treated everything that you can treat, they're still going to have this possibility of falling. And the only thing that you can do in these circumstances is to do what's called off-the-floor practice. And we get our physiotherapists to teach them how to get up off the floor and how to fall properly. A lot of people, they know they're going to fall, they lose their balance, and they have difficulty and they start to grab and so on. There are ways to go down as well as ways to stand up. So that's an important thing to do. Okay, you'll be glad to know I'm not going to chuck anybody out of a window or saw them in half or whatever. Okay?
Describe backward leaning syndrome.
Backward leaning syndrome. Backward leaning is something that people with Parkinson's and sometimes hindbrain strokes get. And what they have is, I'm not going to follow her, but what they have is a tendency to always be going back like this. Now the way to get around that is you need to correct their posture, and you can do that either on a tilt table and bring them upright slowly so as they still feel secure. And the other thing that you can augment that with is to put them prone, face down, in a bed for an hour or so of a day, and that corrects their postural senses. And also, if the physiotherapist is walking in front of them and pulling their hands so that they're going forward all the time, that will correct their posture. It's a case of retraining their posture. And these people feel that that is an upright position. And if you get them to stand up and close their eyes and move them forward and backwards, they feel that they're about to fall forward in more or less the upright position. So you've got to correct that sense of imbalance. Okay?
What about the fear of further falling.
Right. Well, this is the idea that I was talking about, that it's a good idea to teach them how to fall. Fear of further falling, the 3 Fs, means that they've fallen once, they've lost confidence, and when they're up and walking, they're continually reaching for something to give them that steadiness. And in the act of reaching, they keep on falling over. And they're always trying to furniture cruise like kids do before they can walk properly. They move round. And that's it's a loss of confidence. And you need to get around that by just trying to instill the confidence back again. There aren't any medications you can give them.
We had a case a year ago in the clinic. He wasn't particularly out falling, but his gait was awfully unsteady. And I remember the medical student did his exam on this patient, and had the patient walk the line, and the guy was obviously attacking.
Mm-hmm.
And when I went in the room later, I said, "What did you find?" He said, "We found this ataxic gait. The guy had a perfectly fine gait."
Mm-hmm.
And we tried to understand what the discrepancy was, and here the man was walking with his bifocal volume looking down. The medical student had taken his glasses off when he left the room, and then when I came in, he had no problem.
Mm-hmm.
See, that's sometimes, I wish I had it on film.
He's continuing to trying to make a step where there isn't one.
When you look at ataxic, it's a matter of refraction. Not using a bifocal, correct? Something as simple as that.
It's certainly a feature of aging that postural sway increases as you get older. If you get them to close their eyes and put their feet together, they will sway. And women do tend to sway more than men for some reason. As I say, they always sprain their ankle at the most inappropriate moment. But that's a feature of aging, and that adds into all this kind of final straw syndrome that I was trying to demonstrate with singular lack of success. Any other questions?
What about drop attacks? You know, if they looked up drop attacks in the general medicine text, a description of a certain type of epilepsy in this country. I know in the UK, a number of years ago, there was a major, not increase, but a description of this as being a major cause of falls in elderly people. Does that still help the
No,
not epilepsy?
well, they tend to retain consciousness during a drop attack. They just drop to the floor. I mean, it was supposed to be secondary to cardiac arrhythmias. I think the common causes of falling are really postural instability, aggravated by something else. And cardiac arrhythmias as a cause of falling are not terribly high. Really, I mean, we look for them, but it's not something that is terribly high up. In drop attacks, actual drop attacks, unless you can actually witness them slumping to the floor, I think are pretty uncommon. It's usually the fact that they've got a bit of osteoarthritis and they don't see terribly well and they've tripped.
There's no some description that's only occurring in women, no loss of consciousness, maybe even a problem in their cervical spine.
Yes, well, there's this kind of sort of vertebral basilar insufficiency, supposedly. But I don't know that that's really an entity.
So it's really not.
It's not very well defined, no.
One of the tests we do after physical examination is the patient comes to emergency room and a fall, especially if it's the first time. And
Depends how serious the fall is.
what usually happens, the patient doesn't remember, it's a poor history, don't know if past consciousness, if it's which is common.
Really, the kind of test you're looking at, or you want to make sure they're not metabolically upset, you want to make sure they're not anemic, you want to make sure that they don't have an intercurrent infection, which is just presenting as a failure to thrive exhibited by falls or a fall. It's very simple things. You're not wanting a CAT scan, really, unless there's major trauma to the head or there are signs of stroke. A CAT scan will tell you they've got a bit of cerebral atrophy, and you'll say they've got a bit of cerebral atrophy. That doesn't really help you very much. It's somebody who presents at the emergency room. In my opinion, the way we handle it is that we're really only looking for trauma as a result of the fall. And really the secondary bit is that, well, okay, they've had a fall, but can they walk now? That's the question. No, what's their functional capability now that they've had the fall, rather than anything else? And if they can get up and walk about and so on, if they've had one fall, I wouldn't investigate it. I mean, the percentage of people who have a fall over the age of 65 is about 40%. So it's a lot of useless investigation. Unless they've had a series of falls or they're going off their feet, then that's what you're wanting to investigate rather than that single fall itself. Unless they have a very good history of, I had this terrible pain in my chest and I felt rather faint and then I fell over. You know, if you're looking for some valvular heart disease or something like that. So it's just a general physical exam. And then you want to see what their mobility is like then. Very few indications for a CAT scan, I would have thought.
A few months ago, we had a 9-year-old woman with that kind of history and pretty unremarkable physical.
Temperature was what, sir?
It was up like a degree or two. And she was sent home, and then she returned 4 or 5 days later, profoundly ill with urosepsis. Failed to take account of the temperature elevation on her. Maybe ask more questions. I think she had a UTI problem at that time. Maybe early signs. You can often go back retrospectively and say, maybe be a little more curious. Maybe we found the UTI early.
Falls are one of the three kind of main routes of presentation in this age group. You've got falls, you've got poor cognition, and incontinence. Any one of these groups of symptomatology can be caused by lots of differing things. And often you get all three together. So it's just a common route. And what I've suggested today is something that you would do as an outpatient workup, basically. And a lot of it is to do with the history and just thinking about it logically. If you think about it physiologically as to what allows you to stand up and stay stood up, then you'll not miss very much. And just always bear in the back of your mind that failure to thrive in this age group with immobility and falls is often due to an intercurrent infection. And if you just screen for that. Okay. Right. Thank you.
Yeah, I